Unfortunately, right now, all of the treatments we have for advanced lung cancer are palliative. We're not curing very many people at all. So, as I tell my patients, it's quality of life and length of life that are the most important goals of therapy. And in this trial, we're comparing a standard second, third line therapy, erlotinib, with an experimental one targeting the same receptor, but also the other family receptors, dacomitinib, and showed that not only is the progression-free survival longer, but in this presentation they show that by multiple measurements, the quality of life was better for these patients as well. And this was a small randomized phase 2 study, but the improvement in the quality of life on multiple indices was convincing. And when comparing agents for advanced, especially second and third line lung cancer, improvement in quality of life is a major concern for patients. Of course, we would like to see major improvements in survival with our therapies, and with a study of this size, they did show a progression-free survival benefit. And it may be too small or too early to know about the overall survival in this study. But with a progression-free survival benefit and a symptom control benefit, I think it is reasonable to do a study that's large enough to detect an improvement in overall survival. And I understand that's ongoing right now, that they have phase 3 trial. The one concern with the data, first of all, was small, but it was also an unblinded study, so the patients knew they were getting the new drug, and they may have wanted to make it better by complaining a little bit less about symptoms if they knew they were on the new agent. So that always confounds quality of life kinds of things. But also there were more patients with EGFR mutations in the experimental arm. And so that could have resulted in more effective symptom control and PFS in that arm. And so I think going forward it would be important to stratify for EGFR mutations in the phase 3. But all that being said, I think there's scientific rationale for combining HER1, 2, and 4 targeting with improved tolerance and symptom control is important. And so I think those things all argue that the phase 3 is a very reasonable thing to do at this time. I think there is room for improvement, second and third line erlotinib. While it is relatively well tolerated, the vast majority of patients don't get dramatic symptom relief if they don't have, especially if they don't have EGFR mutation. So if it's proven to have the same or better efficacy in terms of progression-free survival or possibly overall survival, as well as improved symptom control, then I think it would at least be a reasonable alternative to single-agent erlotinib in advanced lung cancer.